Hello and welcome. My name is Linda Griffiths. I'm the lead nurse for the Northwest, North Wales and Isle of Man Congenital Heart Disease Network, and I'm delighted to be with you today to present this talk, which is called An Introduction to Congenital Heart Disease. We are going to over the next hour or so, I guess, have a little talk about the background and the context of adult congenital heart disease in the northwest of England. We are going to have a little bit of a whistle-stop tour around some of the common congenital heart defects, from fairly simple right through to the more complex end. Again, very high level, not meant to make you an expert, but maybe for you to go home with some take-home messages. We're going to look at some common emergencies and how to deal with them. A little bit of a focus around the cynos patient in particular and how to look after them. And I'm going to leave you with some contact details for the adult congenital heart team here in the Northwest as well. So that's what we're going to aim to do in the next hour, if we can. So let's start off by just giving ourselves a little bit of context as to what this is all about. Congenital heart disease services now are specially commissioned by NHS England. In 2016, they developed this congenital heart disease standards and specification document that you can find on their website, and it takes you through from fetal life right through to adult care and into palliative care. There are about 13 categories looking at all aspects of care of congenital heart disease. And the aim really is that we are able to provide specialist congenital heart disease care 24/7, as close to home as possible, that we have on-call rotas that are sustainable. So we now have surgery and intervention being performed in high volume centres by highly experienced operators. And we really do have world-leading outcomes as a result of that. We also, the standards talk about care being delivered across a network, and I'll talk to you a little bit about that. In the Northwest, we have, from an adult perspective, all of our surgery and intervention occurs at Liverpool Heart and Chest Hospital. We have a team of 7 adult congenital consultants who are based at Liverpool Heart and Chest, but they provide clinics and support right across the region. So we have a level 2 centre at Manchester Royal Infirmary, which is extremely busy and provides outpatient and investigative work 5 days a week. Very busy indeed. And then we also do an outreach clinic over at Blackpool. We do an outreach clinic at Wythenshawe Hospital in Manchester, and we also do an outreach clinic in Wrexham, Mailer. In addition to that, we also help support the cardiac maternity services from an adult congenital heart point of view. So that's at St Mary's Hospital in Manchester, and then the Liverpool Women's over in Liverpool. And we also have a specialist pulmonary hypertension service based over at Manchester Royal Infirmary, which has shared care with the pulmonary vascular disease unit at Sheffield. And they are looking after adult patients with congenital heart disease only. So you can see it's quite a complex service that we operate across the whole of the Northwest, and we work with several Northwest providers as well. And you might be saying to yourself, well, why is this actually needed? Well, if you were born in the 1940s or before the beginning of the NHS, and certainly before the invention of the heart-lung bypass machine, you probably had about a 20-25% chance of being an adult. If you move this slide through, and I do apologise, it's extremely old, but actually I think it's quite effective at showing how we've continued to improve, because if you were to move this slide further along in this direction and looked at 2026, then this would be saying a 90-95% chance of being an adult now, which is quite phenomenal. And you can see here the sort of points at which we've got better and better at doing open heart surgery and treating some of these congenital heart defects over the years. And that means that so many of these children now survive into adult life, which is fantastic. We know that about 9 in 1,000 babies that are born have a heart problem. That can vary from a tiny hole that might close spontaneously right through to being born with very, very complex congenital heart defects. 95% of children are now surviving into adult life, and adults now outnumber children 2 to 1, and that number is expected to rise year on year. And there's several factors that are playing into that. One is obviously, the pediatric teams are just getting better and better at looking after babies with very complex disease. But we've also got a cohort of adult patients who had their surgery back in the 1950s, 60s, 70s, who we might have discharged back then because we sort of thought we'd fix them. And actually, we now know that we don't do that anymore. So there is a cohort of adult patients who had congenital heart disease surgery as a child who don't know that they should be under long-term follow-up. And they will at some point re-emerge back into the system as a consequence of the surgery that they had as a child. So that's a cohort of patient that we will continue to see for some time yet. And then there is also a cohort of patients who only get diagnosed in adult life. These can be patients with, smallish atrial septal defects potentially, who've gone throughout their childhood and have just been missed, and it's only after decades that they start to present with symptoms as an adult patient. So the numbers of patients are increasing. It is a dramatic success story of modern medicine. There is no doubt about that. It is quite phenomenal, the advances that have been made over the past sort of 6 decades or so. But we do have this new population of progressively more complex patients who are not fixed, actually, and corrective surgery is a myth for most of them. And whilst we don't need to follow everybody up in adult life, we certainly need to follow up a fairly substantial number of adult patients with congenital heart disease in an adult specialist service. So it's really important to know what's normal. If you haven't got to grips with what's normal, you're going to struggle with getting your head around how this can go wrong. It's really important to obviously understand your coronary anatomy, but it's also important to understand your structural anatomy, and that includes the right side of your heart as well as the left side of your heart. It also involves a brand new language. There's lots of terminology that you might or might not have come across before, and we'll touch on some of these as we go through now, just looking at some conditions. So as I said before, we're just going to run through at a very high level some of these congenital heart defects. This is not meant to make you an expert. It is just meant to give you an appreciation of the different types of congenital heart defects and why it's important that people are under lifelong follow-up. So if we start with atrial septal defects, this is where you have a hole between the two collecting chambers of the heart, the two atria. Number 2 there is in the middle. That's a secundum ASD. That's the type of defect that these days you can go to the cath lab as a day case. You can have a catheter inserted through your groin, up through the inferior vena cava, and you can pop a device over that hole. If it's of a certain size and you've got a good rim where the device can attach to, Bob's your uncle, all done in a day, which is amazing. But there are other types of holes in the heart and atrial septal defects. So number 1 here is what we call a primum ASD. It's part of the sort of endocardial cushion defects, and quite often involves a cleft in the mitral valve. That can only be closed surgically and should be done by the congenital heart surgeons. Number 3 and 4 that you can see there, they're sinus venosus ASD. So number 4 here is an inferior sinus venosus ASD associated and is quite close to the origin of the inferior vena cava here. And this is a superior vena cava because it's quite close to the superior vena cava. Now, these types of defects can sometimes be associated with an anomalous pulmonary venous drainage. So you normally have 4 pulmonary veins draining back into your left atrium. Sometimes 1 or 2 of these right pulmonary veins here might be draining anomalously into the right atrium as well. So it's really important that as part of the assessment for that condition that is looked for. And if found, obviously that needs to be corrected surgically, and the surgeon would need to reroute those pulmonary veins back into the left atrium. So hopefully you can appreciate that even atrial septal defects aren't always simple. So let's have a little think about ventricular septal defects. Ventricular septal defects is where the hole is between the 2 ventricles. You will know from your normal anatomy that your left side of your heart is very different to the right side of your heart. The left side of your heart is designed to pump at high pressure. It's about 2/3 higher pressure than the right side of the heart. So if you have a defect anywhere, you are going to get some shunting of blood from the high pressure system to the low pressure system. And initially, when you have something like a ventricular septal defect, you will have that left to right shunt, which is what we refer to it as. So it's shunting from oxygenated blood into the deoxygenated into the right side here. If that hole is big enough, that can cause quite a volume of blood to come across, and that can also expose these lung arteries to that pressure and that volume. Now, lung arteries don't like that. They become damaged over time, and you can develop pulmonary hypertension. So one of the reasons that we want to go ahead and close these holes at an early stage is before those changes in that blood in the pulmonary vasculature has happened. The other thing that you can get with a VSD is sometimes it can be really quite a tiny hole, but in being a tiny hole, it can cause quite a high velocity jet to shunt across from the left to the side, and that can sometimes cause problems with valves as well. So there are lots of things that need to be considered with holes in the heart. They can be multiple. They can be all over the place, a little bit like the atrial septal defects. So they can be in the inlet portion of the ventricle. They can be in the outlet portion of the ventricle. They can be in the muscular region. They can be in the perimembranous region, which is just below the valves. As I said before, they can be multiple. You can even get what you call like a Swiss cheese septum. And if you can imagine, that almost creates like a sieve effect of quite a lot of blood moving across. And we do worry about exposing these lung arteries to that pressure and that volume. So if a baby is unable to go for a full correction straight away and early enough, then sometimes the surgeons will opt to put a pulmonary artery band on the aorta, on the pulmonary artery here. And you're effectively creating a right ventricular outflow tract obstruction deliberately. You will therefore increase the pressure on the right side of the heart here, so much so that you would expect some deoxygenated blood to shunt the other way because the pressure here on the right has become greater than the left. And you will then make that baby have lower oxygen levels than normal. That does sound bonkers on one level, that you are giving a baby lower oxygen levels, but actually, remarkably, they cope quite well with that. And actually, what's more important in this situation is that we preserve those lung arteries from developing pulmonary hypertension, because that's a bad thing. Obviously, when that baby has to go for its full repair, at some point that band will have to come off. And it might be by that time that a little bit of reconstructive work needs to go on that pulmonary artery there. But you can sometimes look through adult notes and see that they've had a pulmonary artery band on at some point. If we sort of stick with the hole in the heart for a little moment, I know this is jumping to fairly complex stuff straight away, but it sort of links into the hole in the heart scenario. So if you have your hole in the heart, was originally shunting left to right, and you've now exposed those lung arteries over a long period of time to that extra pressure, that extra volume, and you've developed pulmonary hypertension, this is what happens. So your little arterioles in your lungs, instead of being nice and healthy like this, they become very unhealthy and look like this. So they develop a very thick wall, and the lumen of the blood vessel becomes very fixed and tiny. If you can imagine all of these little arterioles looking like this, you can then appreciate how the pressure on the right side of the heart will increase. And it will increase to such a degree that the pressure on the right side of the heart will be greater than the pressure on the left side of the heart. And you will shunt deoxygenated blood into the systemic circulation. That's what we call a right to left shunt. When people with a hole in the heart get into this scenario, when they begin to do this right to left shunting, that's when we call this Eisenmenger syndrome. This now becomes a situation that is difficult to treat. You can't close this hole now. If you were to close this hole, this type of damage to your lung arteries will be irreversible, and all you'll do is expose that right ventricle to that high pressure, and it won't cope very well. So actually, the hole in the heart becomes your best friend in many ways, because it allows a bit of a pop-off valve for that pressure. But I guess the downside is that you will shunt right to left, and you will become progressively more cyanosed. And it's not uncommon for patients with Eisenmenger syndrome to have oxygen levels in the 70s and 80s at rest. And if you were to exercise them and maybe do a 6-minute walk test and monitor their oxygen levels, it can easily drop into the 50s and 60s. And then that becomes a systemic problem, doesn't it? Because all of your other organs, your liver, your kidneys, your brain, etc., all has to function off that lower oxygen level. And they are a particularly tricky bunch of patients to manage. So let's move on to coarctation of the aorta. Coarctation of the aorta is where you get a narrowing in the aorta, and it's associated with this little structure here. This is called your ductus arteriosus. It's part of your fetal circulation, and it normally closes soon after birth. And normally when it closes, it just disappears. But sometimes some of the ductal tissue might actually be inside the aorta, and it can cause the aorta to kink and cause an obstruction. Now, again, a bit like with lots of congenital heart defects, there can be a bit of a spectrum to this. So you can have a scenario where this duct closes, and when this duct closes, there is no perfusion beyond this point. And you can imagine that is a critical situation for that baby. They will be critically unwell and will need emergency intervention and be in a life-threatening situation. Alternatively, you can just have a little bit of a narrowing that you might miss and only be picked up in adult life. It might be picked up because somebody just happens to monitor your blood pressure and realizes that you've got abnormally high blood pressure. So there's always a spectrum with these things. In terms of how it's treated, there are various ways that we can treat it, and I can't go into that in a great detail for this purposes of this talk, but narrowings can be ballooned in the catheter lab these days. Surgically, there's all sorts of different operations that can be done. This one here that I'm circling around, subclavian flap repair, is the one that's not done anymore. So this is where the surgeons used to take the left subclavian artery, and they would recruit it and create a flap, which is why it's called a subclavian flap repair. But I'm sure you can appreciate your subclavian artery was never really meant to be an aorta, and you can develop aneurysms over years. So we don't do this type of operation anymore. We do end-to-end repairs, and obviously the technique for doing the end-to-end repair has refined over the years to help prevent sort of restenosis if you get a bit of scar tissue across that. And I guess the other thing to remember from a coarctation point of view, which we'll come on to again near the end of the talk, is to always do their blood pressure in the right arm. You can get an artificially low recording if you do their blood pressure in their left arm. So that's one take-home message to just remember from today. Tetralogy of Fallot is one of the more common reasons why we sometimes refer to, a baby as being a blue baby in layman's terms. There are 4 things that are associated with tetralogy of Fallot. You have a right ventricular outflow tract obstruction, and again, this can vary from just being at a muscular level in the infundibular area here. It might be valvular. It might also extend into the main pulmonary artery as well. It can be quite minor. It can be very severe. You can have a hole, you will have a hole in the heart. You will have a thickening of the right ventricular wall, so right ventricular hypertrophy, and the degree of thickening will be related to the degree of narrowing and how hard this ventricle is having to work. And then what's also a feature of tetralogy of Fallot is that you get during sort of when the baby's in utero and its heart is developing, that central part of the heart can shift anteriorly. And that will mean that your aorta then straddles that hole, and we call that an overriding aorta. So they're the 4 things that are associated with tetralogy of Fallot. We repair these defects a lot earlier than these days than we used to do years ago. Years ago, we used to think that you couldn't take a tiny baby for an operation, and therefore we would have done a staged procedure as a routine. These days, that's not the case. We try and do a full repair as soon as we can, but where necessary, and sometimes it's still necessary, we do need to do this staged approach. And this is called a Blalock-Taussig-Thomas shunt. And this is where we have created a shunt. So because the blood can't get up the pulmonary artery to the lungs, we allow the blood to come up through the aorta, down what was the subclavian artery through the shunt, and perfuse the lungs this way. In the olden days as well, we used to do a classical BT shunt, which is where, again, we would actually recruit the subclavian artery and bring this end of the subclavian artery down to either the right or the left pulmonary artery. And obviously, particularly in the classical BT shunt where the subclavian artery has been used, you sometimes can't find a pulse. It's not a great arm to do a blood pressure in or an oxygen saturation. So it's worth just being mindful of whether they've had this type of shunt in the past. And then again, in terms of types of repairs, there are lots of ways that this can be repaired, but a common repair is what you call a transannular patch repair. This is where the surgeon will put a patch over the hole, They will then deal with this right ventricular outflow tract narrowing and do what's necessary. So they might remove the muscle area if that is very thick, and then they will cut a slit up the main pulmonary artery there, and they will sew a patch in. Very effective at relieving the narrowing, but I'm sure you can appreciate that it's not a repaired valve and this is not a replaced valve. It's had a patch put in it to widen it, and so there will always be a bit of a trivial leak on that right ventricular outflow tract area, which the right side of your heart copes with remarkably well for a long, long time, but it will progress. And as patients get into adult life, this right ventricular outflow tract will become progressively regurgitant and will no doubt need further intervention in adult life. So patients with tetralogy of Fallot are a group of patients who should absolutely 100% be under adult congenital follow-up for life. They are also a group of patients who back in the 60s and 70s might have got discharged because we thought we'd fix them. And these are a group of patients who may emerge through our A&Es as a consequence of the surgery that they had in as a child as well. So let's have a little think about transposition of the great arteries. This is where your main blood vessels are the wrong way round. So if we walk our way through this little diagram here, just to get your head around it, this is the inferior vena cava and superior vena cava, and this is deoxygenated blood entering the right atrium, tricuspid valve, right ventricle. But your right ventricle is attached to the aorta. So that deoxygenated blood is actually going to just be pumped back out around the body. Similarly, on the other side, you've got your four pulmonary veins entering your left atrium, you've got your mitral valve and your left ventricle, but your left ventricle is having a bit of a holiday, just pumping that oxygenated blood back to the lungs. And the only thing that's allowing a bit of mixing here is that good old little fetal heart structure, that ductus arteriosus that sits between your pulmonary artery and your aorta. And you have a little patent foramen ovale that tends to stay open in this condition as well. They're the only things really that are allowing any of the mixing that should occur. So something has to be done here. What normally happens is that we ideally like to get these babies diagnosed antenatally. So before they're born, we will plan for these babies to be delivered at the Women's Hospital, close to Alderhay Children's Hospital. They will be put on a drug to keep this little duct open via a drip, and then they will be sent in an ambulance across to Alderhay. Most of them are going to need some sort of better mixing to occur. So they quite often go to the catheter lab. Soon after arriving at Alderhay, they have a catheter pop through the groin. They work their way through that little foramen ovale, which is part of your fetal circulation. They will blow a balloon up on the left-hand side, and then they will pull that balloon through the atria, and they will create a big hole to allow better mixing at this level. And then they will be a bit more stable then until they wait for their heart surgery. And their heart surgery is done ideally before they're about 4 weeks old. So this is a tiny baby, tiny heart, and amazing surgery if you think about it. What the surgeons are doing here is pushing the blood vessels the right way around, which sounds really simple when you say it, but it's obviously not a simple procedure to be done. You can appreciate that they can't actually swap the valves. So your pulmonary valve is going to have to do the job of your aortic valve for life. They swap the blood vessels a bit higher up here, so they have to disconnect the coronary arteries, put the blood vessels into the correct position, and then reconnect the coronary arteries. And this is in a baby who's 4 weeks old. These babies do remarkably well. They tend to be in hospital for about 7 days. There's 7 to 10 days, and then they go home and they do really, really well. But they do need lifelong follow-up for sure. Obviously, we need to monitor these outflow tracts, and we just need to be mindful of the surgery that they've had on their coronary arteries as well. So I just want to talk about the systemic right ventricle. So if we just go back to thinking about the normal heart, if you remember, your right ventricle and your left ventricle have two different completely jobs to do. So your right ventricle is designed to pump at low pressure and pump to your lungs. Your left ventricle is designed to pump at systemic pressures, about 2/3 higher, and pump all the way around to your toes. They're completely different. But sometimes in congenital heart disease, the right ventricle just has to do the job of the left, and we call that a systemic right ventricle. Just to give you an example of what I mean by this is this transposition of the great arteries that we've just been talking about. And as you know, from the sort of mid to late 1980s, we figured out how to swap the blood vessels around. But prior to that, we didn't know how to do that. And we had a different type of operation, which was called a mustard or a Senning operation. And this is where the surgeons have swapped the blood at atrial level, if you like, as opposed to arterial level. If we walk our way through this, this is your inferior vena cava and your superior vena cava, and it's draining deoxygenated blood. But you can see there that the surgeon has created a baffle for that deoxygenated blood to come across to the left side of the heart. So this is your mitral valve, your left ventricle. Left ventricle is just having a bit of a holiday, pumping that deoxygenated blood to the lungs. Your oxygenated blood is coming back from your lungs in the normal way via your four pulmonary veins. The surgeon will have got rid of the septum, the atrial septum, so that this blood can freely flow behind this baffle. And you can see there that the oxygenated blood is now in the right side of the heart, flowing through the tricuspid valve into the right ventricle. And that right ventricle is now having to do the job of the systemic circulation and push that oxygenated blood around the body. And it wasn't designed to do that. It will eventually start to fail. These patients are prone to lots of rhythm problems as well. If you can imagine, there's lots of scar tissue in the atria, and they are a particularly complex group of patients to manage. And you've got to remember, we were still doing this operation well into the sort of late 1980s for some patients. So we do have, a significant number of adults who have had this type of repair, although we don't do it anymore. Another type of systemic right ventricle is a congenitally corrected transposition of the great arteries, and this is where your ventricles are switched. So this is where you've got deoxygenated blood entering your right atrium, but this is a mitral valve and a left ventricle. We know this because they have specific anatomical structures whereby we can identify them. And then this is your oxygenated blood coming back to your heart from your lungs via your four pulmonary veins, but this is a tricuspid valve and a right ventricle that is then having to pump systemically. So hopefully that sort of helps you understand what a systemic right ventricle is. And I guess it gets more complex than that. So just to hurt your head a little bit, let's just sort of wander into the complex end of the spectrum. You can these days be born with an effectively heart that's got one pumping chamber, so in a single ventricle anatomy, and you can survive into adult life. Invariably, most patients, not all, but most patients will have had some form of surgery to get them to their adult life, and it's a palliation, not a fix at all. You can be born with hypoplastic left heart syndrome, which is where the whole of the left side of your heart hasn't developed. Again, ignore all of this surgery because it's too complex and we don't have time to go into this, but they will have had complex surgery as a child, and their single ventricle that is left is a systemic right ventricle. And we just need to be mindful of that if you've got an adult patient with hypoplastic left heart syndrome, not only are they a single ventricle, but they're a systemic right ventricle as well. If you wander over to the other side here, this is just an example of hypoplastic right heart, if you like. So the tricuspid valve hasn't developed here. We've got tricuspid atresia, and we've got a ventricular septal defect. And then the one in the middle is just to hurt your head a little bit and just to give you an example of how complex it can be. So this is a double inlet left ventricle, congenitally corrected transposition of the great arteries, and a ventricular septal defect. And if you have time to sort of go away to a quiet place and work your way through what it's trying to tell you, you can sometimes work this out. So double inlet left ventricle means double inlet means both atria draining into the single ventricle. It's a left ventricle, and it's a left ventricle because we've also got congenitally corrected transposition of the great artery, so the ventricles are switched. And then, of course, we've got a ventricular septal defect as well. So you're not going to remember all of this anatomy. The important thing that I do want you to remember by the end of this talk, though, is that most adult patients that you see with a single ventricle will have had some sort of palliation, and most of them will have ended up with what we call a Fontan circulation. So this is where the surgeons have tried to find a solution to this. So in the normal heart with two ventricles, your deoxygenated blood will enter the right side of your heart, go to your lungs. Your oxygenated blood will come back to the left side of your heart and go outside your body. what do we do? How do we find a solution where we want the blue blood to go to the lungs, the pink blood to go to the body, but we've only got one pump? And this is the solution that they came up with, which is a Fontan circulation. So if we just look at the picture in the middle, just ignore all the others for a minute. You can see here, this is your single ventricle. Whatever the anatomy is, it's just a single ventricle. And here the surgeon has created a tunnel inside the right atrium. So this is your deoxygenated blood coming in through your inferior vena cava, entering this Fontan circuits, which is a tunnel inside the atria. And then they've chopped up the superior vena cava so that this blood can just passively flow from the bottom end and then the top end into the pulmonary circulation. The really important thing to remember here is this is a passive circulation. There is no pump pumping this blood. It does make sure that all the blue blood goes to the lungs, and obviously all the pink blood comes back into the single ventricle and gets pumped out. So you get that separation of the blue and the pink blood again. But you can appreciate it is not normal. This blood is not pumped, it's passive, it's completely dependent on high central venous pressures. It's also dependent on low pulmonary artery pressures to work effectively. And when we're looking after these patients, we just need to be mindful of that. There's been different iterations of it over the years. These days, we tend to do an extra cardiac Fontan, so this tunnel sits on the outside of the atria. You can see a little arrow here, that's what we call a fenestration. So if the pressure in the lung arteries is bordering on being a little bit high, sometimes the surgeon will create a little pop-off valve, so some of the pressure can offload. That will create that right to left shunt. And if you remember, a right to left shunt means the oxygen levels might not be normal. So if you've got a patient with a Fontan, they should have normal oxygen levels. If they've got a patient with a Fontan who's got a fenestrated Fontan, then you should expect their oxygen levels to be a little bit lower than normal. So I'm sure you can appreciate from all of that late complications are common. We see a significant number of heart failure, which is probably the biggest causes of death in this group of patients now. Sudden cardiac death can be an issue for some. We know that arrhythmias is a significant burden and probably one of the main reasons people end up in A&E. Significant number of patients go on to have residual or recurrent lesions that require further surgery and intervention, and hence end up at Liverpool Heart and Chest to have that done with the specialist adult congenital heart surgeons and interventionalists. Some of them will go on to develop pulmonary hypertension. They are more at risk of endocarditis, and some of them are eventually going to end up needing a heart transplant. Some may need heart and lung. And unfortunately, particularly those with the Fontan circulation and that very inefficient circulation that causes back pressure in the liver, we know that patients with a Fontan circulation are now developing Fontan-associated liver disease as well. So our aim with our patients is to keep them as well as we can. We're very proactive at monitoring, intervening early, trying to keep them away from this requirement to have a heart transplant, because the numbers of patients getting heart transplants is very low. So I hope you're still with me. We're going to have a little delve into emergencies in adult congenital heart disease now. I think the first principle to say is don't panic. You are going to treat these patients just in the same way as you would do any other unwell patient. You're going to assess them in exactly the same way, and you're going to treat arrhythmias as arrhythmias. You're going to treat heart failure as heart failure, and you're going to treat chest pain as chest pain. Please be mindful that their ECG might not be normal. So if you have congenital heart disease, and particularly if you've had surgery as a child, then your ECG might not look normal at all, but it might be normal for you. So you will see right bundle branch blocks, ST changes, etc. It's worth trying to get a copy of their normal ECG to compare if you're not sure. And please feel free to contact the ACHD team. Sometimes the patient might also have a copy either on them or on their phone, so it's worth asking them. But we know that arrhythmias are definitely the commonest presenting complaint to A&E in this group of patients, and you were going to treat them like any other patient, just with a little bit more respect, especially for that complex end of the spectrum: single ventricles, systemic right ventricles, pulmonary hypertension, chronically cyanosed, etc., because they may deteriorate more quickly than you expect, especially people with the single ventricle anatomy as well. If they are compromised, it's far safer to cardivert them electrically. And we absolutely advocate seeking senior ACHD advice, before you even consider sending them home, really, and just make sure. In terms of cardioverting that Fontan patient, so these are a group of patients who do unfortunately periodically suffer from arrhythmias, like a flutter, for instance. But it's really important when you're treating them that you understand that anatomy and you understand the principles of the fact that they need to be well filled, that they have a passive circulation that is not pumped. So incredibly dependent on high central venous pressures and those low pulmonary artery pressures. So it's really important to put them on IV maintenance fluids if they're nil by mouth. We do not want to get them dehydrated. Ideally, an experienced anaesthetist, or pick up the phone and speak to the anaesthetist if something needs to be done locally. Consider whether you need to put external pads on just in case they might need a bit of external pacing immediately after being cardioverted. And we want to try and avoid prolonged positive pressure ventilation if we can. So this is how not to cardiovert a Fontan. So this is a patient who was admitted in flutter at 5 p.m. in the evening, put on the morning list for that DC cardioversion and was nil by mouth overnight but had no IV fluids. The cardioversion got delayed due to an emergency in the lab. So they didn't go for their procedure until that afternoon. And then by the time they got there, they were dehydrated. They had low filling pressures. They then received a vasodilatory drug, which dropped their systemic pressures, which further dropped their filling pressures. And then on top of that, they had intermittent positive pressure ventilation, which increased their pressure within their lung arteries. And that potentially can result in a circulatory collapse and death. And we need to try and avoid that. One of the things that might have made a difference in the whole of this scenario is keeping them well filled. So again, another take-home message, I guess, from today is if you are looking after a patient with a Fontan circulation, for whatever reason, if they are nil by mouth, make sure they've got IV maintenance fluids running and you keep them well filled because sometimes that can be vital. Chest pain. Well, chest pain is common. I guess you need to consider the fact that the coronary artery disease or the risk of coronary artery disease might be quite low in some of our younger patients with congenital heart disease, so they might not have developed some of the traditional risk factors that you see in older age. Except we do know that in coarctation of the aorta, there is a higher incidence of coronary artery issues. And we also need to just consider the patients who've had that arterial switch repair for transposition of the great arteries. That's the one where they've actually taken off the coronary arteries and then re-implanted them. You know, if they are presenting at a younger age with no other risk factors, but they've had this type of operation and they're presenting with, you know, fairly convincing angina type symptoms, then you would want to have a low threshold for investigating what's going on. But the other thing to consider is that our patients are growing older and they are developing those risk factors for coronary artery disease. So you certainly need to be treating them in the same way that you would treat any other patient presenting with what sounds like angina. But do have a bit of a think about other causes as well. If you think about the Fontan circulation, that passive circulation, because it's not pumped and it's inefficient, they can develop blood clots and can sometimes present with a pulmonary embolism at a younger age. So just, you know, have a mindful awareness of that. We do have, you know, a significant number of patients who get a lot of health-related anxiety who can present with chest pain, which can be really difficult to tease out as well. Eisenmenger patients as well, who've got that chronic low oxygen level, can present with right ventricular angina sometimes. That's really typical of angina in that it comes on exertion, it stops on rest. And quite often that's due to a mismatch between delivery and demand due to their low oxygen levels and might not be due to an actual anatomical problem with their coronary arteries. And again, very difficult to manage and is all about pacing and learning to live with that sometimes. And then we've also got obviously our patients with our coarctation repairs, particularly that subclavian flap repair. So if they present with significant symptoms, and particularly if they've got a CT scan that looks like this, then obviously you're going to be on the phone to Liverpool Heart and Chest fairly swiftly for some advice. In terms of mechanical valves, we obviously use mechanical valves in congenital heart surgery a lot. We try not to put them in children because obviously they won't grow with the child and that can cause difficulties, but it's not unheard of and we have occasionally had to put a mechanical valve in a child who hasn't finished growing yet. So if they do present, you know, with significant symptoms, have a high index of suspicion for just making sure that this valve is okay, particularly in pregnant ladies. Pregnant ladies who have a mechanical valve are at particular risk of it clotting off. Remember, some of these valves may be very old. They may be valves that we just would never use these days, but they've still got an old valve in place. And then remember, we've also got a cohort of patients who might have poor compliance, shall we say, with their anticoagulation and taking their warfarin. They might want to go out drinking with their friends. They might want to stop their warfarin, restart their warfarin. They do all sorts of weird and wonderful things with their warfarin, thinking that they're doing the right thing, and they're not. And then in terms of what we do, if this valve has got into difficulties, then we might get away with just re-anticoagulating them. We might need to thrombolize them. We might even need to do surgery to replace this valve. And then please also consider infective endocarditis. This group of patients do have a higher risk of endocarditis. They have a lot of foreign material in their heart, so they might have pacemaking leads. They might have we have leadless pacemakers that sit inside the heart these days. They might have scar tissue. They might have residual leaks. They might have turbulent blood flow. There's been lots of stitching inside the heart. Lots of reasons why bugs might get stuck there. You've got to factor in all the lifestyle issues that are common these days, all the tattoos and body piercings, in maybe areas of the body that aren't particularly clean as well. And the thing is it might be difficult to detect. So some of these patients might present quite acutely, but some of them might present subacutely. They might just have a rumbling temperature on and off, not feeling well, losing weight, night sweats, can't quite get to the bottom of it, backwards and forwards to the GP before eventually ending up in A&E at some point. If you're seeing that sort of picture and the patient's got an underlying congenital heart defect, then really have a low threshold for just ruling out endocarditis. We would suggest that you do the full raft of blood tests to just monitor their infection markers, inflammatory markers, etc. Please make sure that you do a full set of blood cultures, so 3 sets of blood cultures in 3 separate places before you even consider giving antibiotics, and really try and avoid giving antibiotics if you don't know what you're treating. Pick up the phone, speak to the adult congenital heart team. If you're unable to do those screening tests, again, we run a hot week clinic in the northwest of England. We can see patients reasonably quickly, and we can get this done in clinic for you if you just give us a call. And then, of course, there's heart failure. If you've got 2 ventricles and you have got left ventricular systolic dysfunction, then Bob's your uncle. You've got a whole load of evidence-based pathways and treatment protocols that are all in place, and we know they're effective and we will use. The problem that we have in congenital heart disease is that it might be the right ventricle that's failing. It might be a systemic ventricle. It might be a right ventricle that's failing. There might be a single ventricle. They might be chronically cynosed. They might have pulmonary hypertension. We don't have the same amount of evidence that we have for left ventricular systolic dysfunction as we do that we have for all of those. The only option that we have is to extrapolate all of that evidence base for LV systolic dysfunction and just use those medications in our scenarios. But they're used carefully, they're monitored carefully, and the adult congenital heart consultants will want to continue to be involved in monitoring them. It works really well if our adult congenital heart team can work with local heart failure teams, though, particularly for monitoring of heart failure symptoms, so the two can work hand in hand really well together. We will go looking for what's caused it quite aggressively. So have they developed a new arrhythmia? Have they got a new or progressive anatomical problem that could be fixed here? Have they gone on to develop endocarditis? Is there something else going on that we could actually help improve things? So I hope that helps. Just a quick run through of some of the sort of emergency situations that you might be faced with. And now we're finally just going to look at some practical elements of looking after these patients. As I said before, if you remember, if you've got a coarctation, whether it's repaired or not, you really should do the blood pressure in the right arm. If you do a blood pressure in the left arm, you may get an artificially low and unreliable result, and that's not good. You may be also asked to do a right arm, right leg BP to compare. Now, your right leg BP should be higher than your arm. So if it is 20 millimeters of mercury lower than your arm, then that's significant and would need further investigations. So big take-home message from today: coarctation, blood pressure in the right arm only. Similarly, if somebody's got a Blaylock toxic Thomas shunt, definitely if it's a classical BT, but even if it's just you know a more standard BT shunt that's been done recently, just consider whether you should do the blood pressure in that arm. Have you got a decent pulse in that arm, and saturations as well. And then we're going to delve into a little bit around the chronically cynosed patients. So this is chronic cyanosis, not acute cyanosis. We want to make sure that we avoid iron deficiency anemia, which I'll go through in a minute, and we want to avoid dehydration. They tend to have a very high hemoglobin and a high hematocrit, which makes them prothrombotic. So we need to make sure that they don't get dehydrated. We're going to look a little bit around paradoxical air embolus, how to take an accurate clotting sample like an INR. These are a particularly tricky bunch of patients because they can have abnormal clotting factors. They can have low platelets, for instance, but they can equally have very thick, sticky blood with tiny blood vessels if they've developed pulmonary hypertension as well in their lungs. So they can be at risk of bleeding, at the same risk of having a blood clot, which sounds bonkers, doesn't it? But that's the situation that they find themselves in. And we don't have a huge amount of evidence as to the best way and the right balance as to how to treat these patients, and can often mean that consultants are making individual decisions about individual patients here. But let's have a little bit of a focus around the hemoglobin in the cyanosed patient. If you've got low oxygen levels, you will develop an isolated increase in your red blood cells and your hemoglobin. That is an entirely normal adaptive mechanism. And therefore, it's not unusual to see hemoglobins in 180 above 200 and to see hematocrits in the 60s and 70s. We would see that as entirely normal. So if you are looking after a patient who is chronically cyanosed, who has got oxygen saturations sitting at around 85% normally for them, but their hemoglobin is sitting at 130, 140, that is too low. That should be ringing alarm bells to you. You should be, on the one hand, thinking, why is their hemoglobin low? And you should be investigating for why it is low in the same way that you would investigate somebody who hasn't got a low hemoglobin. And you also need to be checking for iron deficiency. When you have a high number of red blood cells, it is really difficult to eat enough iron to create healthy red blood cells. And iron deficient red blood cells tend to puff up a little bit. They get quite sticky. You're more prothrombotic when you are iron deficient than if you've got enough red blood cells that are healthy. So it's really important to check for iron deficiency. It's really important to treat iron deficiency effectively. And quite often that means an IV iron infusion rather than an oral preparation, because it's really important that oxygen delivery to the tissues is maximized when your hemoglobin is high and your oxygen saturations are low. So the other thing to think about is the fact that their hematocrit is really high, and that means their blood is quite thick. And it's not unheard of for you to, particularly for the biochemistry set of bloods, for you to do a sample, it goes down to the lab, it comes back clotted. You do another one, same thing happens, comes back hemolyzed. And you begin to scratch your head around, gosh, I'm taking a really good sample, but I just can't seem to get a result here. And it's because there are a large number of red blood cells in that sample. Those blood cells are constantly breaking down the minute you take that sample. And by the time it gets to the lab, the hemolysis index is off the scale and they won't release the result to you. So the only way that you can do something about this is to treat this blood sample with kid gloves. Use a wide bore needle. So the bigger your needle, the less hemolysis you'll get in your sample. Don't use a vacutainer. A vacutainer causes a lot of hemolysis in the sample, which is not a problem for most people. But if you've got a high number of red blood cells, it'll just break too many down and it'll cause a problem for you. So just use a needle and syringe and a really gentle technique. Don't shake your bottle vigorously. That breaks down red blood cells. And don't pod your bottle down to the lab either. You probably need to phone the lab, let them know that you've got this problem. And the minute you take your sample, walk it down to the lab and hand it to somebody rather than it being sitting in their lab for an hour or two before they get to it as well. So just make sure it's dealt with urgently. And if you do all that, you are likely to get a result. Importantly as well, you're more likely to get a more accurate result. So sometimes you can have patients whose potassium seems to have gone off the scale and it's come back as a hemolyzed sample. So you've got a result, but your potassium's really high, or your liver function's gone a bit off the scale. And actually, what I would suggest you do is just use this technique. Just do a really gentle technique and just check that those results are actually accurate, because invariably, sometimes when you do this, you get a much more normal result coming back. So it is important. The other thing to consider is that a lot of our patients have high right-sided pressures. And they'll be the sort of patients that the veins are sticking out like, like bilio on the arms and the back of the hands. Please just be careful when you finish that, taking that blood sample, that you maintain and stay there until hemostasis has been established. Because if you just ask the patient to apply a bit of pressure and walk away, I can bet your life you'll come back and see that patient the next day and they'll have a bruise from their wrist to their armpit and they won't be very happy. So just be careful. They will ooze like mad after a venipuncture. A little bit about anticoagulation. As I said, they have thick blood. And quite often it's way above this 0.55 range. The problem that we have is that once it reaches this critical point here, you cannot take that blood sample off the shelf and do a clotting sample and get an accurate result. So that might be, it could be your INR, it could be your APTT, whatever clotting sample you're doing. If you're using this bottle, you cannot use it once the hematocrit reaches this level. It is a bit of a faff to get an accurate result, and we don't have another way of doing it, but this is what you should do. First of all, you need to do a full blood count. You need to pick up the phone and speak to your lab and say that you're needing to do an INR or whatever it is you're doing. Patient's got a high hematocrit, it's over 0.55. You send in a full blood count down. They will receive that in the lab, and then they will take the top off. They'll stick a pipette in, and they will adjust the amount of citrate in the bottom of one of those bottles. And they will then pop the top back on and give you a call and say your bottle's ready to be picked up. You need to go down and pick that bottle up. It shouldn't be podded. And you need to handle that bottle really carefully. It needs to stay in an upright position so none of the citrate can get in the top of the bottle, because you're now going to have to do a manual sample. You're going to have to take that top off, and you don't want a bit of citrate in the top of your bottle that then ends up on your work surface. So it must be carried in an upright position. You're then going to do a needle and syringe sample, a manual sample, and you're going to have to manually fill that bottle to the fill line precisely, not above, not below, because the citrate in the amount at the bottom has been adjusted accordingly. And then you've got to pop the top back on. And what I would suggest you do is that you do not pop that back in the podding system, because it's not vacuum packed anymore. That top is likely to come off in the podding system, and then you'll have blood everywhere, and your hospital won't be very pleased with you. So you've got to manually walk that back down to the lab then. But if you do that, you are likely to get an accurate result. If you don't do that, you are at risk of getting an abnormal result. And what can happen is you can get an artificially high result. You will end up under anticoagulating somebody who is prothrombotic, and that can be dangerous. And we have seen cases where patients have come to harm because this technique has not been used. The other thing that needs to be really mindful of is that if you're using a point of care testing device like an INR machine, Roche machine, for instance, they also have the same caveat. If you read their small print, it will say that they don't recommend you dosing anybody once the hematocrit reaches 0.55 if you've used one of their machines. There is a small window where it will continue to give you a result even though the hematocrit is a bit higher than that. It will eventually read an error message, but there is this small window where it will continue to give you a result. You must not dose the patients based on that result if their hematocrit is greater than 0.55. Let's have a little think about paradoxical embolus. If you or I have an intravenous fluid running, it will go from our veins to the right side of our heart, and it will go to our lungs. And your lungs work as a perfect sieve. They sieve out small air bubbles and keep you safe. If you, however, have got a big hole in the heart and you are able to shunt from the right side of your heart to the left, so you've got a right to left shunt, then you can potentially bypass that safety mechanism of your lungs when you've got an intravenous fluid running. And those air bubbles can potentially go straight into your systemic circulation and cause a TIA or a stroke, which is the reason that we suggest that you use an air filter in patients who have a right to left shunt or are able to shunt right to left. and you place it right near the cannula. It's normally a zero point 0.2 micron filter. It is patients who have got this shunt, and we absolutely recognise that if you're not confident in this anatomy and adult congenital heart disease, that you might not be able to tell the difference. Not all cyanose patients have a shunt, for instance. Our sort of rule of thumb is if you're not sure, stick one on. You might find that the adult congenital heart team come round on the ward round and can reassure you and just say, actually, that's okay, you can take that off. They're not shunting right to left. And then you can make a note of that on the note. So if you're not sure, pop one on or seek advice. They do come in different sizes. The 0.2 micron filter comes in a 24-hour filter or a 96-hour filter. So sometimes it's helpful to have the 96-hour filter on. The blue one there is a 1.2 micron filter. Filters there as well, but it's only a 24-hour filter, that one as well. So you just need to pick the right filter for the right scenario. Not everything can be filtered, unfortunately, so you can't filter blood products. You just can't. So you're just going to have to be vigilant about how you run it through and just be mindful that this might be a risk. You cannot filter fluids that are being pushed through at high volume very quickly. So for instance, if your patient needs to go for a CT scan, and they want to give the patient some dye for that CT scan that's pumped through very quickly, you'd have to take the filter off. The filter would just break. So there are some limits to this as well. And then I just want to leave you with a little bit about DeGeorge syndrome. DeGeorge syndrome is a syndrome that's had lots of names over the years. It's in its more up-to-date form, it's called 22q11 microdeletion. It has congenital heart disease as part of a spectrum, but that spectrum also means that they are prone to having low immunity, so at risk of infection. So your aseptic technique should really be spot on. And they are also at risk of host versus graft disease following a blood transfusion. Now, although that risk is low, it is universally fatal. And so if we know that this patient has DeGeorge syndrome and we are planning a blood transfusion, then we always make sure that they get irradiated blood for that purpose. So that's just worth knowing about. And then, of course, probably this is the most important bit about this talk, because this talk is aimed at non-specialists. We know that our number of patients is growing. They're getting more and more complex. They're living longer and longer. They are going to interact with every single aspect of the NHS in the same way that you or I do over the years. So anybody watching this talk now has the potential to bump into patients with congenital heart disease, some of whom might have quite complex congenital heart disease. Hence, we just want you to be aware of some of these issues. We want you to be aware of the fact that it's okay to ask for help and when to ask for help, because this can be really important. So there are lots of places where you can get extra information. This 2020 European Society Guideline for the Management of Adult Congenital Heart Disease is probably the most significant guidance that's come out in the last sort of 5 to 6 years or so. Covers most things. It's not particularly evidence-based, but then we don't have an awful lot of evidence to support what we do in adult congenital heart disease anyway, but there are lots of good advice in there as to what to do. There are bits and bobs around that might be a bit old now, but still useful if you happen to get your hand on them. The app on your right there is, potentially a useful resource. It's comes from the Cincinnati Children's Hospital in America. It has a full library of congenital heart defects that are animated, so you can see them pre-op, post-op, a little bit of narrative behind them. And it's free, and you can have it on your phone. If you're looking after some of these patients a bit more frequently, so you might be in an ITU setting, for instance, at Liverpool Heart and Chest, you might want to know a little bit more about this. This book has been written by the team in the Brompton in 2022, so it's up to date, and it is an advanced nursing care guide for adults with congenital heart disease and is very good. We also have some e-learning for health modules on the Health Education England platform. They are aimed at non-specialists too. So there is an overview of congenital heart disease, and there is a paediatric module and an adult congenital module on there as well. We also have our website. Please go and have a look at that. There are lots of resources and information on there as well. And you will see that we periodically have educational sessions, webinars, face-to-face sessions, and we will also advertise anything else that's going on both locally and nationally as well, should you want to be involved and know about those. So finally, just some details about how to contact the team should you need them. We have an adult congenital heart helpline. It's 01512543333. That is a number that can be given to anyone, patients, families, anybody can call that number for help and advice. It does go to a voicemail message. Those voicemail messages are taken off Monday to Friday periodically throughout the day, and they're triaged. So if you ring up with a fairly urgent call, chances are you'll get a call back the same day. If it's less urgent, you might get a call back in 2 to 3 days, but it does go to voicemail. Our nurse specialists also carry an on-call mobile phone that you can see there. That phone is picked up. So if you physically need to speak to somebody that day, that's the best way to speak to one of the nurses. And then, of course, our consultants are available 24/7 for emergencies via the switchboard at Liverpool Heart and Chest. And that is for the northwest of England, North Wales, and the Isle of Man. So please just be aware of that. So finally, have a low threshold for seeking expert help. Let us know if you've got an ACHD patient that you're either looking after on a ward or in primary care or wherever it is, and you are a bit concerned that they might not be under follow-up in particular. Please give the team a call and just have a chat with them and make sure they're under the correct and appropriate follow-up. From a personal perspective, take a little bit of time to understand what's going on with your patient. What were they born with? What surgery did they have, if they had any? What's normal for them? What's their oxygen saturations normally? What is their blood pressure normally, etc., etc. What does their ECG look like normally for them? That will help you look after them in the here and now and notice any changes. But it is definitely okay to know your limitations, and we would absolutely support you seeking help. If you are a nurse and you want to be linked into the ACHD Link Nurse Forum, by all means, either email the network on the email address that you can see there, or there's a contact form on our website as well that you can contact us via that route as well. So thank you so much for joining me. I do hope that that has been useful. And please reach out to the network if you need any further information or support. Thank you so much.